Our next session is another important and enthralling topic. Brachytherapy, either in the form of radioactive iodine seeds or HDR or LDR brachytherapy, has been an integral part of prostate cancer management for many years. However, there is a declining trend and enthusiasm about the use of brachytherapy in prostate cancer. In this session, we are going to see what is the current status of brachytherapy in prostate cancer and where we stand at the moment and where we are heading in near future. May I request Dr. Arunabh Sengupta, Senior Surgical Oncologist, Apollo Hospital, Kolkata, and Dr. Supurna Ghosh Roy, Madam, Senior Radiation Oncologist at Apollo, Kolkata, to join us and chair the session and introduce our speaker. May I have the slide
Good
for
afternoon.
Professor T. Sharma?
Good afternoon and thank you. Thanks the organizer for asking me to chair this session on brachytherapy in the management of prostate cancer, current status and future directions. Speaker is Dr. D.N. Sharma, he is the HOD, Radiation Oncology, All India Institute, New Delhi. He is also Editor-in-Chief Journal of Cancer Research and Therapeutics. So, Dr. Sharma, welcome.
Sir, it's my proud privilege to chair the session of my teacher, Professor D.N. Sharma. I'm fortunate enough to chair a session, who was my teacher. Whatever I am today, maybe due to him only. He was a finest brachytherapist. He is the finest brachytherapist in India. And in brachytherapy, he has an immense knowledge and his passion, I think, is brachytherapy.
I request don't take the chairperson seriously. Anyway, respected chairpersons, ladies and gentlemen, a very good afternoon. Thank you for inviting me. Thank you, organizing committee and scientific committee, especially Dr. Animes, for not ignoring brachytherapy for the management of prostate cancer, because it's really not frequently discussed in various meetings and conferences. So this is the step one for any modality you want to promote, to discuss it frequently and make the people aware, and that's how you can increase the use of particular technique in a site like prostate where there are multiple modalities. Just to keep it simple, I will not go in much into the details of the literature. For the ease of management, the prostate cancer is divided in three categories: early, advanced, and recurrent. And just to give you the glimpse of the role of brachytherapy in the prostate cancer management, in early stage and early risk patients, you can use brachy as a lone modality of treatment called monotherapy. In the intermediate and high risk patients, you can use as a boost therapy in combination with the external treatment to the pelvis and to the primary tumor. And even in recurrent cases, you can use it for a salvage treatment, especially post-RT patients, So brachy, as most people think, is not only meant for the early stage and early risk patients, it is across all the patients, population of the prostate, from early to high risk and even recurrent cases. Just to again give a brief, outline or brief the situation of the brachy in prostate cancer in India. It remains a grossly underutilized weapon for the management of prostate cancer. There are many reasons for this, but I think most of the reasons are the regions which can be sorted out. First is that the majority of the patients present in the late stage and advanced metastatic stages, and there are very few patients who will be eligible for brachytherapy. Then the second reason, the lack of expertise and lack of resources for doing the prostate brachy, and the various other competing modalities like robotic surgery we just heard, and then even in radiation armamentarium we have like SBRT, we have proton now and brachy, so there are multiple options. And in a way I would say the prostate patients are lucky that they have multiple options to choose. They have the luxury that they can choose a treatment as per their own need and suitability. Just to tell you, the early stage prostate cancer, there are three competing options like watchful waiting or active surveillance, surgery, whether open or robotic, the surgeons will decide. And then one of the options is radiation treatment as well. Now let's not debate which is the best of these modalities, but there will definitely be a subset of patients who will be eligible for surgery, and some will be for like active surveillance. Some will definitely be eligible for even radiation therapy also. So when we offer radiation treatment to these patients, there are multiple options within radiation treatment itself that we can offer to the patient, and these are like IMRT, SBRT, brachy, proton, cyberknife. There are multiple area of technology nowadays in the current era of radiation treatment. But when you choose the EBRT option and not choose the brachy, you must keep all these factors in mind. Although all these EBRT options, especially the SBRT, proton, and the various other techniques look very fancy, but you must not forget these are time-consuming exercises, and they require a high and very strict, stringent quality assurance. The cost is also a factor in these treatment modalities, and you will also definitely require some kind of gating or tracking, because prostate is one organ which has the motion artifact, so you will require either gating or tracking. So therefore, you will add cost, and then you will add the high maintenance and even the quality assurance as well. Now, just to tell you that some people might think that the brachy is a declining art, it's a dying art, and it's not very popular. But this is just one, although I can convince that it's not obsolete, it's still technique which is sought after in many countries. This is one article which was published from the Canada, and as you can see the title, excessive wait list and delays to treatment with low dose brachy predict an increased risk of the recurrence. Now, if a treatment will be wait list only if it is in demand, or if it is required for a treatment, you will not have a waiting list or delays if a technique is not very popular. So it's not that the brachy is not popular, it is still popular in the countries where it is available. And even within our own fraternity of radiation treatment might be thinking that why choose brachy when we have SBRT, we have IMRT, we have other treatments, so why choose brachy? So just to convince you that brachy has certain attractive features which can compel you to choose brachytherapy. First is that the most conformal treatment. Across all the treatment modalities in the radiation treatment, brachy is the most conformal treatment. High dose of radiation which can be delivered by brachy, you can deliver almost like 150, 180 gray, which you cannot deliver with other techniques like IMRT or SBRT. Treatment is very short, it's a very brief treatment, and the local control is very, very good. I'll show you in just a couple of slides. And the quality of life, especially the erectile dysfunction, is more or less intact in a very good number of patients. And cost effective, you don't require a very large machine for delivering the brachy treatment. And as you can see, the dose follow, the nature of brachy treatment is that the dose follow is very, very sharp. You can see like the dose outside the CTU is very less, and the dose within the CTU is very high. If you can see the dose escalation, brachy is one treatment which can give you auto escalation. You don't have to do anything extra for escalating dose within the CTV. As you can see, near to the needles and the catheters, you have more than 200% doses. So you are doubling or tripling the dose without doing anything, So you can escalate the dose unlike other modalities, And if you see the anatomy of the prostate, you have bladder, you have prostate, near to the prostate and your rectum, which are very close, and they are very critical organs. If the distance is only millimeters, if you do a SBRT treatment, if the rectum comes into the CTV, it will get the same dose as the CTV, so there is a high risk. And people have been comparing these modalities, that which one is the best. This is one paper I would like to quote. This is from United States of America, where the prostate is very common, and people tend to, even the patients will ask, what is the ideal way of treating us when it comes to radiation treatment? So they did a trial. It's only a dosimetry comparison trial, where 5 modalities which are available in the United States, they compared all of them, and they are enlisted in their insurance handling agencies as well. So first was VMAT. As you can see, the VMAT gives a very good distribution, but you still have some spillage outside the target, especially the low dose spillage, but that may be an area of concern, although it's not a high dose region, but still it can be a concern. Second is proton beam therapy, or not only proton, it's intensity modulated proton therapy. So dose is far better than VMAT, but still have some entry doses on the 2 sides where the beam are entering. The third is the carbon therapy, which is biologically much more effective than the protons. And again, the dose is very dense in the center, if you can see from the proton beam distribution. And again, the problem is that you have entry. In EBRT, the problem is that the dose has to enter from, the beam has to enter from somewhere in the body, So you'll have some doses on the entry sides as well. Now, the fourth picture is the low-dose brachytherapy. And you see the dose distribution is much better than even carbon-ion and even the proton beam therapy. And if you see the high-dose brachy, that is even better than low-dose, because with optimized tool, you can further shape the dosimetry. And your dose to the adjoining organs is very, very less. You don't have to bother about the various other organs in the pelvis. So if you see the dosimetric, on the merit of the treatment, the brachy is the best treatment available as far as dosimetry is concerned. People have been injecting hydrogel to increase the space because EBRT technology has realized that until you add something in between the rectum and the prostate, your dose to the rectum is going to be high in some patients. This is one study I would like to, I will not go in detail, but this is one study where the three modalities was compared: surgery, radiotherapy, active surveillance for the early stage prostate cancer, where all these modalities are competing modalities. Survival is exactly more or less same. You can't even differentiate the line at the top. But if you see the erectile dysfunction, it was best with the radiation treatment, especially the brachy. Active surveillance was the same, and if you see the surgery, the erectile dysfunction was much higher in that, I'm not saying that the surgery is inferior to the, in a given patient where the erectile dysfunction is not a matter of quality of life for an elderly patient, it is more or less same. But you have data where the radiation treatment scores over other treatment modalities. Now let's come back to the Indian scenario. Can we really push up the use of brachytherapy in a country like India? Well, I think so, and I'll convince you why I think so. First, that we have to create an awareness in the caregivers and patients, and it is being done, especially in discussing the various conferences and meetings, so that people can be aware and they can be made to realize that it's not a very difficult and tedious treatment, it's a simple treatment. The incidence of prostate cancer is rising, and that will be 100% rising the incidence of prostate cancer in 2040 as per the Globocon data. So it is going to be a major health problem in another 15 to 20 years' time. It's already a third commonest cancer in many of the metros. In fact, in Delhi, it's the second commonest cancer. So the incidence is rising in the some of the cities. Brachy gives you excellent dosimetric potential, as I showed in the pictures, and the clinical efficacy is very, very good. So far, whatever trials we have, it gives you good local control, less toxicity, and even the lesser erectile dysfunction. It is very cost effective, and it's a simple technique to learn. Many people think that it's very difficult to learn. I will show it is not that difficult. Now, and many people will say that we have lack of resources, lack of expertise. That's a relative factor, and prostate brachy is very, very resource friendly because you don't require a very large machine. It's a very simple mobile machine. You can keep it anywhere in the operation theater, or you can keep it in your brachy room as well. Proton beam therapy, when you can procure proton beam therapy, why can't you get a simple machine like brachytherapy and the prostate assembly? And expertise, that's again a relative factor. If you want to learn, it will be available to you. And just to tell you why prostate brachy is simple, because it is anatomically accessible region. It's just behind the pubic symphysis, unlike cervix or the lung or the pancreas, where you can't access these organs, So you can palpate it very easily. You can do a truss guidance, which gives a very good image. I've been a fan of this truss image for cervix and the prostate because it gives very good image just next to the prostate that you have the probe and you can see the entire tissue. The tissue tube implanted is very small, unlike cervix where you put almost like 20, 25 needles. Here you don't need to put so many needles, so risk is not that much. And it's a silent malignancy. If you commit some errors, you have a backup of the EBRT and you have hormone therapy. So small errors can be buffered, if you are going through a learning curve. Just to give the example, this is the cervix patient left side. And in this, you can see almost like 25 needles have been inserted. But in prostate, you don't require many needles. So again, I would say it's not difficult. It's simple because you just need to put like 10 or 12 needles and the job is done. Implant procedure, I will not go in details because we don't have that much time. But if you want to do it, there are multiple guidelines in the literature. You have especially the EBS guidelines. From time to time, they keep refining these guidelines for doing the brachytherapy. So there is no depth of literature on the guidelines. But you need a dedicated ultrasound machine. This is one simple machine which is available in most centers. So this machine you need if you want to practice the brachy for the prostate. And this is a very simple technique. On the truss probe, you mount a template, and this on the image, you can see the other side. You can see the image that, sorry, it's not working. So you have the prostate image, and you have all these holes which are on the template. They are superimposed onto the image, and you can choose which one to load. And Nowadays, there are software that even during the implant procedure in the OT, you can know how much dose will be delivered to the tumor and how much dose to the normal tissue. Just like you put a needle and you see the dosimetry. Again, you put a needle, you see the dosimetry. So likewise, even during the procedure, you can see how much dose is being delivered to the urethra and to the entire prostate. And if you see some region is underdosed, you add a needle there. So you have the luxury of putting the and shaping the dosimetry even in the operation theater, and you don't need to do a CT scan or MRI. Simply an ultrasound is good enough to see it, to implant, and to do the dosimetry as well. You can see in all sort of sections. This is our study, but I will not go in details. Published in Brachytherapy way back in 2016. It was for the boost because we don't get many early patients. So if you want to try prostate brachy, start from boost, because then in boost you have some buffers. If you commit some errors, again you have 45 to 50 gray as XMB treatment as a backup treatment. This, I'm going to skip this. This was our data, but this was the conclusion of the study. Simple technique. If you don't have the that assembly which I showed you, the online dosimetry, you can still do it by putting two needles on the right and left edge of the prostate and see on the ultrasound, and then you just put the template there. And if once you fix the template with those 4 boundaries, it's very easy to put the, of course you need a truss guidance for putting the implant, you know. Seed implant, the technique is the same as the brachytherapy, because it's the same technique you have to do it. Only thing that you have to have seeds, which are not available really in this country, although we are 3 centers, we are, they are on tips. Hinduja is one, then Kidwai is one, another center. But again, they also struggle to procure the seeds because it's just like buyers and the vendors problem. Vendors say that we don't take takers. The takers say the seeds are not available. So just a situation where the seeds are not available. But the good about the prostate implant by seed is that you deliver. It's a one-time procedure, and you deliver almost 150 to 180 gray by this seed brachytherapy, and the dose is delivered very slowly over the period of time. This is one study which I like to quote, like Oka Prost from the Kidwai Memorial. Anyway, just to conclude, the incidence of prostate cancer is rising, and therefore we need to realize that it is going to be a major health problem in another 15 to 20 years. Prostate brachy has excellent dosimetric potential and clinical potential indicated not only for early, it is indicated for early, advanced, and recurrent cases. The ground reality is that the practice of brachy is limited to a few centers and remains grossly underutilized. We need to take measures so that we can promote the use of brachytherapy and benefit the needy patients. Thank you very much. Sorry, I exceeded just 2 minutes of time.
Thank you, sir, for your excellent lecture. I think very few centers in India practice this brachytherapy, and AMC is one of the center. And that is because of you. You regularly practice brachytherapy in prostate. So excellent lecture. Any question from the floor?
Sir, I am from CNCI, Kolkata. So we have just started the HDR implant for prostate.
Very good,
and we have procured one on Centra and truss-guided ultrasound and the grid. Actually, it is so easy a procedure. The ultrasound gives the lateral view and the end-on view, and how much I am going, I can see through the ultrasound, and also the grid guides me what are the number of needles and what is the positions of the needles. So it is so less time consuming, less costly, and I have done myself a few cases, sir. I am very happy with that.
Very good.
I have not followed it up. Still, I have given 3 fractions to a patient. Sir, so what should be the I have done in limited volume disease. So what should be the
I would say
gap
you can
between
do
the gap between the.
I would say you can do it for even advanced cases also, where the surgery is not being done for some reason, and you can choose them for first giving the 45 to 50 gray by extended beam treatment, and then you can give boost by boost. We are giving typically by 9 gray times 2.
Yeah, but sir, for monotherapy in limited volume, what should be the fraction?
Okay, good. There are multiple fractions, but if you ask me, the dose which we follow is 9 gray times 4.
9 gray 4.
Just 9 gray times 2 in one session, like 1 week, and then after a week or 10 days, you can give another 9 gray times 2. Some people give 7 gray times 5. Some people give like 6 gray times 5. So multiple, But as long as your dose is about 40 gray, near to 40 gray, it's fine. That's right.
Thank you, sir.
Okay.
Sir, what about toxicity in your patients?
Toxicity, it's mainly, again, ultimately it's a radiation technique. So Some of the patients get the proctitis in the beginning because with high dose rate, they will have the difficulty during the passage of the stools and pain during defecation. That's the only difficult I see, but it is less than 5%. I would say it is not a bothering trouble for the patients. Within like month, 2 months, they come back to their the good quality of life.
Thank you, sir. Thank you for
Thank
your
you.
excellent lecture.
Thank you.
Thank you.
So before we conclude the session, may I request our chairperson to hand over a memento to Professor D.N. Sharma, sir, as a token of appreciation. So we are thankful to sir, you have taken time out from your busy schedule and come all the way from Delhi to Kolkata for the session. Thank you very much, sir. Thank you.